Nandita quickly because she should.
Yeah, ma'am.
सर लाइव स्ट्रीम कहाँ पर है आपका, जरा सा बताएंगे?
It is live on YouTube, ma'am. Just it has started streaming on
YouTube.
Yes.
अच्छा.
And I'm starting the recording also.
Okay. YouTube का सर link है?
Link will be providing. I'll be providing once I start. I'll be providing in that common platform.
So please do ना society में post कर दें.
Right, ma'am. Good evening to all. This is Ranjit Sahu, Marketing Head with Walter Bushnell. Welcome you to this webinar. ISAR chapter invites you for the ISAR theme CME on 12th April. And this is very much important in terms of webinar from the UK chapter on a very important topic, that is unexplained infertility. We have our eminent panelists all across the country who will be talking on this topic, and followed by there is a panel discussion, that is case-based scenarios in infertility. With this, I hand over to Akriti ma'am to take it forward. Akriti ma'am, over to you, ma'am.
Ranjit ji. Aarti ma'am, shall we wait?
Yeah, you can. In the meanwhile, you can welcome everyone, and called ma'am. She should be joining. Yeah.
A very good evening to everyone present here. I welcome all the esteemed faculty and all the participants who have actively shown interest in this webinar, ISAR themed webinar on unexplained infertility, which is being organized by Uttarakhand ISAR chapter. I am Dr. Akriti Gupta, and under the able and dynamic leadership of Dr. Aarti Luthra ma'am, we've organized this webinar in association with Walter Bushnell. And I would request now Dr. Aarti Luthra ma'am to carry forward the webinar.
Good evening, dear friends. Hi, Dr. Nandita. Good evening.
Hi.
Good evening, ma'am.
Good evening, ma'am.
Good evening.
Congratulations.
Thank you. Sorry, what are you doing? Yeah.
At the outset, heartiest congratulations, Dr. Nandita, for taking over as President, National ISAR. And congratulations to Dr. Sujata Kar for taking over as Honorary Secretary General too. This is our first webinar with our new President and Secretary. We welcome Dr. Nandita to be a part and the chief speaker of this webinar. And may I start by introducing Dr. Nandita first? Akriti, would you like to share ma'am's slide? Thank you. Dr. Nandita needs no introduction, as she has been actively involved in various FOXY activities, EMOGS activities, and we have been seeing her at the forefront of all workshops and organizing various seminars at national levels and international levels also. Ma'am is current President ISAR 2022, and Dr. Nandita has been President EMOGS 2020 to 2022. She's been former President FOXY, former President IAG, former Chairperson MSR, and Dr. Nandita is director at 9 Bloom IVF centers. So that's the magic. Ma'am is so actively involved with all the academic activities, and she's managing these centers so well with wonderful results. And she's Professor OBGYN at DY Medical College, Navi Mumbai. And Dr. Nandita is recipient of honorary COG from Royal College of Obs and Gynae, UK. And she's been practicing infertility for more than 25 years, and she's written more than 150 chapters and received various awards, and she's delivered more than 61 orations. And she's the recipient of Bharat Gaurav Award and recipient of IMA Award for contribution in medical field in 2019. We all have been eagerly waiting to hear from Dr. Nandita what she has to share about unexplained infertility. But before we start the session, I would like to invite Dr. Nandita to share her views as president of ISA. Over to Dr. Nandita, please.
At the onset, first of all, I'd really like to thank Aarti and Akriti that it's really a pleasure to be here at the Uttarakhand chapter. Can you take off this sharing of the slide, please?
Akriti, yeah, you have
Can
to
you
stop sharing.
Yeah, hi. And Sujata, can you switch on your video? कल से छुपे हुए हो आप है क्या Sujata? Or
Yeah, Dr. Sujata is actually, she's been in touch with me and she had told me that we'll be playing the video first.
No. So I think, I don't know where she's, or she's.
There.
Yeah,
I'm there.
the
Why
name
are
is
you hiding? Why are you hiding?
No,
Yeah.
my video is on, but it is showing Akriti Gupta below my name.
Yeah, Mr.
Oh, there
Yogendra,
you
you
are.
have to change.
Okay,
I'm
ma'am,
there
I'm
for-
doing. I'm doing.
Yeah.
What has
Just
happened
I'm
is
doing.
that I have logged in from 2 devices.
Okay. Welcome,
My
Sujata.
presentation is in my laptop, and here I am on my phone. That's why.
No, I wanted to, just say that Sujata has worked really hard. This was something that, as a president, I had a vision that we have to be inclusive, and all the chapters should be this. We wanted this to be a physical meeting, but I think unfortunately, it's just not possible to be everywhere physically. And this was the month of, we wanted to do unexplained infertility. And Sujata gave me the most difficult topic of talking on unexplained infertility. And the whole of, the week, I was like thinking, kya bolu kya main? And I have kind of prepared something, but I think what we need to understand is that infertility is really something very stressful condition, and unexplained amongst that is very, very difficult problems. And I'm going to talk about it. But Sujata, you've worked really hard. And here on this platform, I really want to say thank you to you.
Not at all.
This is the baby she has taken from me, and and has really run with it. And every month we are having fantastic programs. So I'm really happy that the entire country is going to be involved. And I think next time, Sujata, what we must do is we must share the links all over the country. We must put it on we must broadcast it and ask everybody to tune in and listen to it. Because I think all the topics are really wonderful, what has been decided, and everybody can share and participate in the whole thing. So congratulations, Aarti.
Nandita, we've already broadcasted it.
Okay. Congratulations, Aarti and Akriti. And maybe we can do more to, get to more people to come in with us and be part of it. So thank you. Thank you for letting our vision come true. I think that is important, that you all have, got together and are doing this thing. And we would definitely love you all to be part of our association. Thank you.
So we would like to start. Dr. Sujata, are we, now we don't need the video, na? Because ma'am has been live, this thing, ma'am has shared her views. So we'll be starting the first session, and I would like to invite the chairpersons for the first session. May I invite Dr. Vinita Gupta and Dr. Ruchira Nautiyal to chair the first session. It's my pleasure to introduce Dr. Vinita Gupta, a very close friend, and she's head of the department at Shri Guru Ram Rai Institute of Medical Sciences, Dehradun, a very busy center where they do a lot of high-risk pregnancy and other work. Dr. Vinita has over 60 publications, and she's got the Best Poster Award at AICOG Bangalore, and she's got the Kamini Rao Yuva Foxy Oration Award at AICOG 2004 Agra. Ma'am has organized various state-level conferences, including North Zone Yuva Foxy, which was held at 2018 at Dehradun and which was attended in large number by all Foxy members. Dr. Vinita, can we see you? Have you?
I'm there.
Oh, yes.
Yeah. Hi.
Okay.
Hello, everyone.
So our second chairperson for this session is Dr. Ruchira Nautiyal. Dr. Ruchira is a very young and dynamic gynecologist, and she heads the Department of OBGYN at Himalayan Institute of Medical Sciences, a very eminent institute for medical education in the outskirts of Dehradun. Dr. Ruchira has teaching experience of 19 years, and she's published over 35 papers in Index Journal and presented at AICOG. She's the scientific coordinator for Uttarakhand Society of OBGYN, and she's the coordinator for UG competencies for
Thank you. Thank you, ma'am.
I think Akriti, you can take over. There's some problem at Aarti's end.
I think let's begin.
Ma'am, are you there?
We all are glued to listen to Dr. Nandita. Let's begin with the session right away.
Perfect.
Should I start, Dr. Ruchira and Dr. Vinita?
Yes, ma'am. Please.
Yeah, because
Please,
they've already.
we are all waiting to hear you.
Thank you.
Yes.
Thank you
Yeah.
so much. Let me just do, because this is a very different kind of a talk.
I know.
I am going to be talking more. Good evening, everybody. I think with both the head of departments over here, I'm like, whether to go evidence-based or whether to go practical. I think I'm going to take the middle path, a little bit of evidence-based with a little bit of practical knowledge. I think is very important, especially for this part of infertility, that is unexplained infertility. It's a very simple talk where what is the definition of unexplained infertility? I think if we look at it, unexplained infertility is that infertility which doesn't have a cause. I mean, from time immemorial, we know that we have ruled out all the causes, like simple things like ovulatory dysfunction, any tubal factor, any male factor. And then if we don't find any cause, then it is known as unexplained infertility, where we cannot find any discernible cause. And so the evaluation in unexplained infertility becomes very, very important. I remember when I began practicing infertility, that is nearly 30 years ago in the 90s. I mean, we didn't have much investigation to do. And now as we progress, there were certain tests which came forward and a lot of unexplained became explained. So what were the investigations that are really important? I think what has really changed unexplained infertility over the years is a few things, like something called the low ovarian reserve. I think a lot of it, nearly 30 to 40% of my patients of unexplained infertility demonstrate a low ovarian reserve. And that is one of the causes of unexplained infertility. So when I talk to a lot of audiences about doing an AMH, because it is very important, because it helps us to classify these patients who are poor ovarian insufficiency or poor ovarian reserve. And that is a category of patients which was first, before we could do AMH, was classified as unexplained infertility. So remember that this whole chunk of patients has now got out of unexplained infertility. Then another there was a very interesting paper, whether to do laparoscopy in this group of unexplained infertility or not. So in the evaluation, of course, there is blood tests, there are, ultrasound, etc. But ultrasound and the tubal evaluation, that is you can do a HSG, but whether to do a hysterolaparoscopy or not, that used to always be a question. Now, remember one thing, what we do is, if we find a patient with poor ovarian reserve, I like to put in a laparoscope, for the simple reason that sometimes these patients have tuberculosis, which is undetected. And the tuberculosis may be responsible for the poor ovarian reserve in our country. And also there is a genetic preponderance for poor ovarian reserve. So you can study 300 to 400 genes, which will actually tell you that there is LH receptor polymorphism, there is FSH receptor polymorphism, there's EMH receptor polymorphism, there's MTR receptor polymorphism. These are the different receptor polymorphisms, the SNPs which are affected, which actually give rise to poor ovarian reserve. So they get out from the unexplained infertility. But there is a group of patients where if you do the hysterolaparoscopy and you can find mild endometriosis and mild adhesions, like a tubal factor, mild tubal factor. So a lot of patients of unexplained infertility could also belong to this group, mild endometriosis and mild tubal factor. And the hysterolaparoscopy can actually be diagnostic as well as therapeutic in these patients. So it's very important that we evaluate the patients of unexplained infertility properly. So remember that if your patient has not conceived in a year, if she's under 35, it is important to evaluate. An evaluation should be complete. So serum AMH should be part of the evaluation. And also if the AMH is low, I would even do a genetic analysis of this patient and also a hysterolaparoscopy in these patients, because that will help me not only diagnose, but also will be therapeutic in at least 30% of the patients of unexplained infertility. Then what happens to the rest? Obviously, what happens to the rest is very empiric treatment, because we have no other way to treat them. It is totally empiric. So we go on to the empiric therapy in these patients. So IUI or natural cycle. We can either do IUI or natural cycle. So do you do IUI in a natural cycle? This is the ASRM recommendation of 2020. This is what I was talking about, evidence-based. It has been written that if you do natural cycle, it is less effective. So it's better to use clomiphene citrate with IUI. So clomiphene citrate with intercourse, there is no difference. So better to use, if you give a clomiphene citrate and tell her to have sex, actually it's no more effective than just telling her to have plain sex. So clomiphene citrate with intercourse, not really recommended. Letrozole with intercourse doesn't really make any difference. Gonadotropins with intercourse really does not make any difference, because costly, the number of follicles increase, multiple pregnancy, and complication rates are much, much higher. What about clomiphene citrate with IUI? Yes, it does make a difference. It is good and you should use it. The pregnancy rates are about 12.5% and it makes a lot of difference. But remember, with IUI, 1 or 2 follicles only. If it's more than 2 follicles, you have to cancel the cycle. Letrozole with IUI, yes, it is a good treatment protocol and it should be used with IUI. But again, the same thing as clomiphene citrate, only 1 or 2 follicles. You should not use more if there are 3 follicles over there, because obviously multiple pregnancy. And then IUI with low dose gonadotropins, actually, they are more complex, expensive, and likely to be not more effective than oral stimulation with oral medication. So gonadotropins with IUI in unexplained is actually not recommended according to evidence-based medicine. What about the conventional dose, that is high dose? High dose is not used at all, though it does give a better pregnancy rate over oral medication, but also because it's high dose, it has high multiple gestational pregnancy rate. So you should not use it at all. The timing of intrauterine insemination. It is recommended that a single IUI be performed between 0 to 36 hours post HCG injection. We use 36 hours. At 36 hours, we can do an IUI and you can get a pregnancy. So a single IUI is more than enough. IVF. I think IVF is, remember that it is important to understand that the current evidence does not support IVF as the first line of therapy for unexplained infertility or expectant management for 6 months. Remember, the first 6 months, you have to give expectant management, especially in a girl who is less than 38 years of age. But it is important to remember that if the age of the woman is more than 38 years, remember that IVF is associated with a higher pregnancy rate and shorter time to pregnancy. So like right now in practice, I get women who are 40 plus. Recently, I've got a woman who's 44 years old and she had a normal AMH. She had normal semen parameters. She was not unexplained infertility, but she had got married late and she had not conceived in 6 months. So kind of you can put her in the unexplained infertility group. But what we did was we did egg pooling for her, got all the eggs together and then started doing embryo transfer. And by the second cycle, she had conceived. And then, so you cannot spend time on doing IUI on a 44-year-old because the pregnancy rates are very low. So you have to individualize the treatment according to the patient. So I think age plays a very important role over here. And if your AMH is 2, within the lower side of normal, I think you should expedite the treatment rather than go for expectant management or IUI. I think IVF works very, very well. Then, of course, those who fail to achieve a pregnancy following a course of clomiphene citrate with IUI, then immediate IVF results in shorter time to pregnancy. And definitely, as I said, in women less than 40 years, if you don't wait for too long and switch to IVF faster, you'll get pregnancy much faster. And there is good evidence that there's no reported difference in clinical pregnancy and live birth rates when comparing IVF with conventional fertilization, IVF with ICSI in unexplained infertility. That this is, in fact, some of the latest studies which have come that you can do IVF or you can do ICSI and you can get the same results. There's no fertilization failure or anything where unexplained IVF patients are concerned whether the girl is under 35 or more than 35, whether she's 40-year-old, because male factor is not seen in these patients at all. So there's good evidence that there's no reported difference in clinical pregnancy or live birth rates whether you do IVF or ICSI. However, ICSI has been associated with higher fertilization rates and a reduced risk of complete fertilization failure as compared to conventional fertilization. And that is why, I mean, you know, people like me who've been practicing for 30 years, we tend to do ICSI in these patients because, you know, getting a fertilization failure is not an option in these patients. Any patient, you tell them there's been no fertilization, but of course, once when the law comes, we will have to give them the option of IVF before, because we will need to, you know, work by the law properly. Everything will have to go by evidence base. So what is the recommendation by the ASRM? It is recommended that couples with unexplained infertility initially undergo a course, typically 3 or 4 cycles of ovarian stimulation and IUI with oral agents. For those unsuccessful with oral agents and IUI, treatments with oral agents, IUI and treatments with oral agents, IVF is recommended rather than, you know, gonadotropins and IUI. So instead of switching over to gonadotropins with IUI, it's better to go for IVF with IVF. So in unexplained, it's better to switch treatments rather than to go with IUI with gonadotropins. Another very, very important thing which I want to say before I go away, you know, infertility itself, of course, has a lot of depression. Mental health is an issue, and this law which is there in our country has actually addressed it, because therapy and counseling is a must for each and every couple that is there. And especially in unexplained infertility, what the studies have shown and what I have seen in my patients, there's a lot of anxiety rather than depression, because they cannot understand that why they're not getting pregnant. So that anxiety has to be taken care of. I think it's a lot of addressing the issues, explaining to them that something must be wrong at a micro level. You have to sit with them, give them time, and explain to them that how we are bypassing certain processes. You know, there could be a problem with the egg may be too thick, the sperm cannot penetrate. So bypassing all these steps by doing IVF ICSI when they've not conceived, ovarian stimulation and IUI. So I think it's very important to relieve the anxiety. And trust me, the anxiety part, once you relieve, the pregnancy rates are also so much better. So I think I would really, I know this is a very short and sweet lecture, but this is what I want to talk also. And as I was researching for this lecture, I want to share 2-3 points also with you all. You know, there is another that we do HSG with lipidiol. That is also one of the treatments for unexplained infertility. Remember, when we do HSG with the oil-based dyes, it has shown the beautiful studies by Neil Johnson, which says that mild endometriosis and unexplained infertility gives you very good results. So using lipidiol is also very good. But of course, you have to do the kidney RFT and the LFT before you subject this patient to using lipidiol. And the other thing is that any patient of unexplained infertility, please evaluate her completely. I think we must, instead of doing a normal HSG, you can do this lipidiol HSG in her to check whether if it works. And after the lipidiol, subject her to 2 or 3 IUIs. If it doesn't work, then you can go for an histolaparoscopy and see if there's mild endometriosis or a mild tubal factor, and then jump straight to IVF. Thank you. Thank you very much. Sorry, this was very short and sweet, but I just wanted to give some take-home points and discuss the evidence base as well as give you some practical tips. Thank you. Thank you very much.
Ma'am, could I ask a question, please?
Please go ahead.
Ma'am, what is your experience with lipidiol? Because is it more painful because it's oil-based, or?
It is a little difficult to perform and slightly more painful, but you have to fit it in properly.
Yeah.
And it is messy.
Yes, because that's what our experience was. So we used it once and then we found that it was more painful. Patient were not as comfortable as the
And it's
other.
expensive. It's very expensive.
Yes, it is very expensive. True, ma'am.
Madam, I too have it was a very, in fact, a crisp talk that you just put across. I mean, I would just like to have it from you to bridge the gap between an ovarian induction IUI and to the IVF and ICSI. If adjuvants we could look up to adjuvants as to bridge the gap. I mean, what is your take on this?
See, these are all normal patients,
Yeah.
with the normal ovarian reserve and everything. So yes, I do add adjuvants like, vitamin D, I would supplement. I would give melatonin. I would give omega-3 fatty acids.
Okay.
I give CoQ enzyme because these are antioxidants. So, and generally just advise them the high protein diet, so that it's good for fertility, that the high protein diet, alpha omega-3 fatty acids, they're good for fertility, the fertility promoting diet,
especially
that
vitamin D coming up in a big way.
Vitamin D is a big deal in our in our profession right now, fertility. So I think that is something that we can recommend. But otherwise, in unexplained infertility, I don't know. I mean, there's a lot happening on the molecular level. Like I was reading, unexplained infertility and recurrent implantation failure, but nothing really concrete has come about. There are a lot of receptors which are upregulated, downregulated, and a lot of recommendations that you can identify these, inflammatory markers and all. But right now, they're very, very in the basic phases. So, you know what, I feel with the advent of precision medicine, we will not have this idiopathic causes left anymore. But maybe 5 years, 10 years down the line, we will be able to say that there's no unexplained infertility.
True.
But till then, it's too expensive right now. I mean, I am doing all kinds of tests in my patients in Bombay, but it is not evidence-based, what I'm doing. I'm doing precision medicine in my practice, but I have to counsel the patients that it is not evidence-based. It is way ahead of times what I'm doing. And it may be useful, it may not be useful. So it's very difficult to get a patient to spend 50, 60,000 rupees when you tell them that iska kuch fayda hoga ki nahi hoga. And so, yeah, but it's happening. There's a lot of advances. Actually, my whole oration in, AICOG was on this precision medicine. And I talked about it even in obstetrics, in gynecology, in HRT, and in infertility. I think we are going to see a huge change in the way we practice 10 years down the line. It's going to be all individualized medicine depending on your genetic profiles. Pharmacogenomics is here in a big way and it's invading every field. Right now, it's only in cancer. But yeah, unexplained infertility will get explained. Trust me. But till then, we have to work how we are working.
In the right direction, of course.
So I think I should thank Sujata that she made me really read a lot. And, there's so much knowledge right now in my brain because of this talk. So, and thank you. I'm really happy, Sujata.
Otherwise, the topic would have been COVID-19, and this one would have killed us.
COVID-19.
Yeah, I think
we don't want to talk about it.
We're all walking into hospitals without masks now. I'm fed up of the mask.
Yeah.
Seriously.
We have shifted to regular simple masks rather than
I can't breathe only through the N95.
Totally.
My one question to Dr. Nandita.
Yes.
My one question to Dr. Nandita. What's the role of tunnel assay? Tunnel assay in cases of unexplained infertility.
Sorry, tunnel assay.
Tunnel assay. Considering the male infertility.
Sperm DNA fragmentation. See, sperm DNA fragmentation is a cause of male infertility. Okay, definitely it is a cause. In fact, it's one of the things which has been said in recurrent pregnancy loss. So if that is there, it doesn't become unexplained infertility. So I would definitely do that test. For male factor, I didn't touch upon it, I'm sorry. But yes, in male factor, I would do semen analysis, semen culture, and the sperm DNA fragmentation. These are 3 tests which we would do. And if the DNA fragmentation is high, then I would give antioxidants to the husband. And if it is treated, great. If it is not treated, believe me, a testicular biopsy and getting the sperm from the testes helps, because there the antioxidant, I mean the oxidative damage is the least. So you can actually pick up the sperms from there. But usually antioxidants would be good. Yeah, TISA would be good.
TISA would be good. Better, it can give a better result.
First, you should try the non-invasive. You should try giving antioxidants for at least 3
antioxidants have been given.
TISA would be a good way to help them.
Mild OATS is there, not excessive also, but mild is there. And DNA fragmentation is in the range of 15 to 50.
You can do microfluidics, or you can do MAC for sperm separation technique, because it will remove all the DNA, the apoptotic sperms. So you can use those technologies to separate out the sperms.
Thank you, ma'am. Thank you.
Madam, one more thing I want to ask is, like you said, ovarian stimulation with gonadotrophins is not recommended nowadays, and instead we go for IVF. Yeah, with IUI. And rather we go for
unexplained. For unexplained infertility. But dekho, Vinita ji, you know what? We have to be very practical in life.
Yeah, that's what. So in clinical practice, sometimes we have to do it.
People don't want to go for IVF. Then I would use low dose gonadotropins. I would use a combination of CC gonadotropins. That's what I said. Now, 2 HODs are sitting with me as the chairperson. I mean, I such bolu ke evidence based bolu.
Yeah, because sometimes, you know, the patient does not want to like straight away like go for IVF.
Not ready for IVF. Not ready for IVF.
Just to give them some time, and then
you can do
the
CC
cost.
100. Yeah, you can do CC 100 milligrams and 75 international units on day 6, 8 if you want alternate day, or you can give every day also. It helps. But again, you know, you have to be careful of multiple pregnancy.
And what about the role? Like, are you giving like DHEAs to improve ovarian reserve, or it's just empirical?
Yeah, if it's a poor reserve, I use it. I use it a lot.
Yeah.
I believe in DHEA.
Okay.
I use it a lot.
And suppose, madam, you have a young patient, say around 30 years, and her AMH is like quite poor. So then should, like, because of her age, and if you are seeing AFC is good enough, then what
I would go for IVF straight. I would actually go for IVF, because her chance of getting pregnant is much, much better. Or what I normally do in these young girls is, if they're not willing for IVF, you know, then I'll tell her, just take your eggs, create the embryos and freeze them. And I will do IUI for you. If you don't conceive, I will use these frozen embryos. Because if the AFC is good, take it. But again, if she's not willing for that at all, do IUI, she'll get pregnant. See, age is very important. And AFC is good. If AFC is good, you will get eggs. If age, AFC and AMH is poor, no, you're in a bad situation.
Yes.
Normally, the AFC is good. Then even if the AMH is low, you'll still get eggs.
And nowadays, you also have like young girls who don't want to have a pregnancy, and they come for like oocyte, just retrieval and all. Yeah. So
please do it, madam.
No, we will do it, but like at least I motivate them to have a pregnancy rather than
of course. You always motivate them,
because age later on when she's elderly,
you have to understand that the girls are dynamic today. They want to study, they want a career, they want to do things in life before they tie themselves down to a child. So give them that freedom.
Yes.
I'm not asking you what age you had your baby.
It was a very good talk, I think. Just clear messages you have given us. 2-3 clear messages. Very crisp and good talk.
Thank you, madam.
Sujata really made me work very hard. You know, to make this talk interesting was very difficult.
Yes.
Okay, thank you. But it was good. I had such a beautiful audience, interested audience. That makes it very interesting. So, Aarti, I think you have a wonderful, group. So, Aarti, I think you have a wonderful, group. I think Aarti's
My internet connection.
internet is very, very unstable.
Am I audible now?
Yeah, you're audible now.
Yeah, my only question was, when do you declare to a couple that I think you're suffering from unexplained infertility? It's post laparoscopy, post IUI. When do we tell them? Because this is a difficult task to declare. We don't know what's the cause. And
I think after all the tests, not even laparoscopy, I would do it before the laparoscopy. After the tubes have been checked by HSG. I would tell them that 99% you're unexplained. Laparoscopy will only make me rule out endometriosis and mild tubal factor. But the HSG kind of gives us an idea if the tubes, there's a free spill and all, it should be okay.
Nowadays, patients are also very intelligent. Many times they label themselves it unexplained. कि हमारा ट्यूब्स भी ठीक है, follicular monitoring भी हो गया, सब कुछ हो गया, तब भी बच्चा नहीं ठहर रहा है. तो पता नहीं क्या कारण. So they come in the criteria of unexplained by themselves only. Many times I've seen.
Yeah, Dr. Google.
Dr. Google. But we have to rule out.
The faster that you talk to them, the sooner that you counsel them. As I told you, there's a lot of anxiety. So you need to, talk to them because they are anxious. What is happening? What is wrong with me? Which we don't realize. It's more of anxiety than depression. See, there's a difference. And when I was reading this paper on anxiety and depression, I realized the difference. And we don't realize it when we are talking to patients. And it's important to realize it because it will help you when you talk to the patient will be yours when you allay the anxiety. They're not going to go from patient to doctor to doctor. Otherwise, unexplained infertility patient just jump from doctor to doctor. So remember that if you realize that it is anxiety which is the problem and you talk to them and you allay the anxiety, I think that's important.
Dr. Nandita, you are absolutely right. Actually, we have seen when we are doing IVF, those patients who are very calm, cool, the embryo transfer, after embryo transfer, most of the time they conceive.
Yeah,
those patients very anxious. They say, what will happen? Is this cycle will successful or not? They are not able to.
And 1,001 questions where they don't trust you, trust you.
Yeah, that is the thing. And one thing is very important, Dr. Nandita, as you have told, down the lane in next 10 years, we are not going to have unexplained infertility, that all the microbiological factors we will be able to diagnose. Absolutely. So I think we can remove this word unexplained infertility near future, and we can give the right diagnosis to our patients.
Absolutely.
A very, very lucid and very informative talk. Very, I'll say it is a very practical talk you have given.
Thank you.
Thank you very much. I'm glad you all enjoyed it.
It is, yes. So can we move on to the next session now? All our panelists are eagerly waiting for this. Dr. Sujata. Welcome, Sumita. Good to see you.
Hi, Aarti.
Hi,
how are you?
I'm good. Thank you.
I had told Akriti I'm a little stuck with another program, but then yes, I could manage to join in.
Nandita's lovely presentation. It was very nice. Yeah. But now we are going to start with panel. And Akriti, may I invite you to introduce the chairpersons to the panel? And first, I would like to invite our Secretary General ISAR for the year 2022, Dr. Sujata Kar, a very good friend and a thorough academician. Dr. Sujata is practicing gynec endoscopy and ART for last 25 years in the beautiful city of Bhubaneswar. And her area of interest is, of course, PCOD, proteomics of male infertility and scope of stem cells in gynecology. And she's, this is her CV, I believe. Ma'am is managing executive committee member of IAGE, PCOS Society and FPS of India. And she's been conferred with many awards like Parache Award for Women Achiever, Odisha, Devi Award for Dynamism and Innovation from Chief Minister of Odisha, and Brand Icons Excellence Award 2018 for Best IVF Center in Eastern India. Akriti, let's invite our chairpersons for the panel discussion.
Yes, ma'am. Thank you, ma'am. I would like to welcome Dr. Upendra Uli, sir, who is MD from Government Medical College, Jabalpur, and he is currently the Director of Oli Hospital, Infertility Center and Diagnostic Center at Haldwani, Nainital, Uttarakhand. He's been the Vice President of Uttarakhand Chapter of ISAR 2018 and Secretary General of IMA Haldwani 2015. He's a life member of ISAR, IFS and IMA and a member of FOXI and ICOG. Welcome, sir.
Thank you, Anand, for a nice introduction.
I would also like to welcome Dr. Niruvesh ma'am, who's the director and consultant in Meher Hospital, Dehradun. She's the present president of Uttarakhand Society of Obstetrics and Gynecology and immediate past president of Gynae and Obstetrics Society of Dehradun. She has received many awards to her. She has many awards to her credit. Medical Excellence Award by Chief Minister of Uttarakhand in 2018 and Medical Excellence Award by Dainik Jagran on Doctors Day on July 2021. She's specialized in ART, infertility and high-risk pregnancy, and she's been speaker at many national and international conferences on different topics. Ma'am is a life member of various societies like FOXI, ISAR, IFS, and welcome, ma'am.
Thank you, Dr. Akriti, for the kind words.
Ma'am, I would like you to please introduce our panelists.
Sure. So we have a very knowledgeable and very talented panelist in this panel discussions. This is the case scenarios regarding the different cases of infertility. We have Dr. Sumita Prabhakar. She is MRCOG 1998. She is PGD HHM Symbiosis Pune, Secretary Dehradun and Ops Gynae Society 2004. She was the President Dehradun Society 2013 to 15. Consultant and head of the Department of OBG Gynae CMI Hospital. She is the Director of Care IVF Unit Dehradun. She has got a special interest in infertility and endoscopy. She is the President Can Protect Foundation, doing work in remote areas of Uttarakhand in screening and the improvement of the women's health. Regularly presents papers in national and international conferences and invited as faculty. She is doing a great work for eradication of the carcinoma cervix in the whole of the Uttarakhand. Next panelist. Great work you are doing, Sumita.
Thank you.
We are all inspired by you. Our next panelist is Dr. Reema Sarkar. Very smiling and very cheerful person. She is the central head of the and consultant in the IVF specialist and obstetrician at Indira IVF Center, Dehradun. She is the ex-associated professor of OBGY GMC, Faridkot, Punjab. She has more than 10 national and international publications, contributed more than 15 chapters in various gynae books. She is the reviewer with the Panacea Journal of Medical Sciences. She is the Wonder Foxian Award 2019. She has got Wonder Foxian Award 2019. Welcome, Dr. Reema. Our next panelist is Dr. Anupama. She's a walking encyclopedia, I will say. You can ask anything to her anytime. She is graduated from KGMC Lucknow. She did MD from MEMC New Delhi, Fellow in Reproductive Medicine from NUH Singapore, owner and the senior consultant at Futela Hospital, Rudrapur, Uttarakhand, founder president of Rudrapur Ops and Gynae Society, affiliated to FOXI, President Rudrapur Ops and Gynae Society. She is the executive member of the Uttarakhand Society of Ops and Gynae, pioneer in the infertility at Kumaon region, gifted the first IVF baby. Faculty in various national conferences, conducts gynae ultrasound and the IUI training workshops in own center. She's contributed chapter to 2020 Foxy Publications Handbook of the Drugs in Infertility, conducted various workshops and the conferences on Uttarakhand infertility and obstetrics topics. Co-founder of NGO at Uttarakhand. Welcome, Dr. Anupama.
Thank you for the introduction, ma'am. Thank you so much. Coming from you means a lot.
Thank you, Anupama. Welcome you here. Next panelist is Dr. Ritu Prasad. She is the Secretary IFS Uttarakhand chapter and gynecologist, infertility and IVF specialist, consultant Prasad Hospital, Rishikesh, and she is the head of the Morpheus Prasad International IVF Center, Dehradun. She has a lot of affiliation in her credit, advanced training in the reproductive endocrinology and ART from BAD Mundar, Germany, Foxy recognized ART training course from Ruby Hall IVF Center, Pune, presently working as Secretary IFS Uttarakhand chapter, worked as the Secretary of the Obstetrics and Gynae Society and ISAR UK chapter for consecutive 2 years. She's conducted many CMEs, national as well as international speakers in field of ART and ultrasound. Welcome, Dr. Ritu. Next.
Thank you. Thank you, Dr. Meenu.
Thank you. Welcome here, Dr. Ritu. Our next panelist is Dr. Shilpa Sharma. She's a reproductive medicine specialist and director at Brenda Femicare Fertility, Dehradun. Recipient of IOG Satya Paul Award 2016 for Best Original Study. Awarded Dr. Day Award by IMA South Delhi Branch 2018. She is an invited faculty at various conferences. Founder member of the Fertility Preservation Society India. She is a member of the IFS, ISAR, Foxy, FPS, ISFP. Welcome, Dr. Shilpa. Good to see you here.
Thank you, Dr. Meenu, ma'am, for such kind words. It's an honor. Thank you, ma'am.
Welcome. Our next panelist is Dr. Jyotsna Agrawal. She is very academic oriented girl and she is affiliated to, she is the Secretary Foxy Roorkee 2021 to 22, affiliated to Foxy AOGD, WALS, IFS, ISAR, Fellowship in Assisted Reproductive Technique from PD Hinduja National Hospital, Mumbai, Fellowship in Minimum Access Surgery, MRCOG London, Part 1, and academically inclined and aspiring professional clinician, expert for over 13 years. She has special interest in promoting and managing reproductive health. She is the gold medalist, certificate of honor and appreciation in academic and socio-cultural events, presented scientific papers and posted in national and international conferences. She has conducted various public awareness campaigns and put forth her thoughts on health issues on women at various forums on high repute. Welcome, Dr. Jyotsna.
Thank you, ma'am.
Okay. Over to Dr. our moderator. Moderator.
A very good afternoon.
Yeah.
Good evening to all of you. And thank you, Dr. Meenu. And Dr.
Let me say a sentence about Dr. Sujata. I'm sorry, I'm barging in. Sujata is, embodiment of energy. When I was in a conference together along with her at morning 5 o'clock, when I went out at the beach, I think I went out at 6:30 or something, and she has already taken a 1-hour run and everything she has managed before the day started for rest of us.
So in that case, you have to see me after 9 or 10 o'clock in the evening. My batteries are down.
That's why she's so fit.
Yeah, absolutely. Very, very inspiring.
Thank you so much. And I'll just start my slide. So first and foremost, thanks to Aarti for kick-starting this fantastic state chapter focused CMEs that we have planned for the year. And Uttarakhand, as you can see, is the first chapter to start this CME. It is just that we are doing it virtual. Otherwise, if we would have had time, I'm sure Aarti and all of you would have had a fantastic in-person event as well. And I'm sure we will have it sometime in the in the year. There's a lot of time there. Like Aarti said, Dr. Nandita and myself took over in March, and Dr. Nandita as the president. Like, see, the thing is that no secretary or no managing committee can perform without a encouraging and a president who is free thinking, gives you a free hand, is open to your ideas. Nobody can perform. So that is a thing which nobody, I mean, I don't have to say that. So I am 100% sure that this, which is her brainchild, is to connect with the state chapters. I have only done the groundwork. I have done nothing. I have taken her idea and just tried to liaison with the state chapters. And I hope this will be a big success through the year. So we, as you have seen, we will plan every month, one theme, and we will coordinate with 2 state chapters. April is the month of unexplained infertility. Initially, we had planned COVID-19, but then correctly said by Aarti that COVID is gone, and it almost gone kind of, and it will not have much significance if we discuss art in COVID. So we changed to unexplained, and then and then Chandigarh chapter is also doing this particular CME on another day this month. So unexplained infertility it is. And I'm sure you'll all agree that this is the topic which most suits this most important saying by Socrates, which is, all I know is that I know nothing. And unexplained infertility fits so well into this. And usually unexplained infertility is a non-diagnosis. It is a lack of diagnosis. After doing all standard investigations like the tests of tubal factor, tests of ovulation, tubal patency, and seminal fluid. By NICE guidelines and by most guidelines, these are the 3 important things which have a direct impact with pregnancy. The other tests that we do usually do not always have a very direct correlation with pregnancy. So, but then these 3 important tests, if they are normal, and if this diagnosis is very, very variable depending on your patient population, but it has been applying to as much as 15 to about 40% of the patient cohort that you deal with. And there was a question back there when after Nandita finished her talk, was if I hope a day will come when we will be able to do, I think Dr. Meenu only said that, a day will come when we will be able to not have a diagnosis of unexplained infertility. We will have all the tests that we can do, and I'm sure we will pinpoint. But I'm sure the day when 100% implantation by IVF will come before, we will find a cause for all the causes of unexplained infertility. So let's hope that we are there. But for now, even with all the sophisticated tests that you have in hand, even if you've done them all, I believe that as much as 15% of patients will still fall in the category of unexplained infertility, where everything will be normal that we can test for. So today we'll have just a very simple, practical discussion. And I'll invite all the panelists one by one. And because in a panel discussion virtually, it's very difficult, to kind of discuss. So we'll just try to, focus one question for one person and then, move on so that it's easy to discuss. So this is the first case. She's a 26-year-old, married for 2 years. She's a teacher and she's anxious to get pregnant. She has regular menses, mild dysmenorrhea, no sexual complaints in either partner, and she's been regularly cohabiting for 2 years. No medical chronic illnesses in either partner, no prior surgeries. There are no significant family history. The mother has hypertension. There are no addictions, occasional alcohol, BMI is 26.4, husband is average height, built. The routine blood tests, a transvaginal scan, HSG, and a seminal fluid analysis. These are the 4 tests that I do usually in the first line. They are all normal. By and large, they're all normal, except for WBC, which you always find in seminal fluid in our country. So given a course of antibiotics, other than that, all are falling in the regular category. So let me start by asking all of you one by one. Let me start with Sumita. In fact, all of you one by one, you could answer. What will be your choice for this patient? Expectant management, further investigations, or some form of treatment? Just tell one of these.
Yeah. So good evening, Dr. Sujata. This patient is only 26, married for 2 years, no obvious high risk factor. So yes, of course, reassurance, telling her to do some kind of lifestyle changes. She could lose some weight. Her BMI is little on the higher side. And
So you are for expectant management?
Yes, I'm for expectant management with lifestyle modification, encouraging her to lose some weight.
Okay.
And waiting for some time. Yes, I'm in for
Okay.
expectant
I'll come back
management.
to you. So you are for expectant. Dr. Reema?
Hello, ma'am. Ma'am, can we go back to the slides for investigation?
The previous one?
Yes, ma'am. Investigation. Yes, ma'am. I would also say expectant management.
Expectant management. Dr. Anupama?
Hi. For this patient, the first thing which I would want to do for her would be ultrasound telling me that what is her ovarian
ultrasound
reserve.
is done. Ultrasound is done.
Yeah, the ovarian reserve, because there
I
nothing.
will
no
show you
details
the
are there.
ultrasound also. So you would like to go for further investigations?
Yes. I would want to know. I would want to do a follicular monitoring for her for 1 cycle at least.
Okay.
Know how her body is responding, how her follicles are going, whether it's rupturing it or on time or not, whether she's following it or properly or not. This would be my standard first time management now for this patient.
Okay. And Dr. Shilpa, Dr. Josna, just tell me what will be your broad plan next?
No idea of thyroid and serum prolactin.
That has been done already. Routine blood
Because
tests,
these are also
thyroid and
important tests.
prolactin.
Routine. These are normal.
Yeah.
Ma'am, has a semen culture been done for him? Because
No
you've
culture
started.
is done.
Ma'am, I
Sorry,
would
ma'am?
like to know whether she knows her fertile time, because she is a young patient, recently
She is a
married.
teacher.
Yeah.
No, so the point is, my question to all of you is, how many of you are going for expectant management? Because see, I think only Anupama said that she would go for further investigations. I'll come back to her and ask her what investigations.
She's already 2 years into infertility. So after
Yes.
2 years, I would want to go further.
So Anupama would want to go. So I think all of you are for expectant management, right?
No, ma'am, we would like to go further.
I would go for further
because it's been 2 years. So with 2 years, you would like to start something for maybe, it's follicular monitoring and maybe ovulation induction just by Clomid or.
Okay. So actually, I can't see all of you at one time. So was that Akriti?
I'm Shilpa here.
Shilpa.
Mine
Right,
is
Shilpa. So you would like to
dysmenorrhea,
go for
mine
some kind of a
dysmenorrhea.
treatment, right?
Yeah, ma'am, I would, because 2 years and the patient is with now it's been 2 years that they have been trying. So while
Okay, so I'll come back to you with some treatment.
Ma'am, usually when the patient or such couple comes in first visit, 1 month we go for we can go for expectant, but from second we can start.
1 month is too short a time for expectant management.
Oh, ma'am, but we are not known that they know fertile time. She knows her ovulatory time or not. Because sometimes patients say they are staying together at the time of menses or during menses. So sometimes it's a very simple thing of timing.
Yeah,
that's what I wanted to say in such type of couple. So you need to.
She's a teacher, I think. No, teacher. I think
the
teacher knows the
Right.
fertile
Okay.
time.
So I think let us move ahead. So of course there is a role for expectant
She's
management.
educated.
But usually I think almost all guidelines and all the papers that we read would tell you that 2 years is quite a bit for a regular cohabiting couple generally. So this is some statistics that I pulled out. In general population, at the end of 1 year of regular cohabitation, 84% will conceive. At the end of 2 years, 92% will conceive if they are regularly cohabiting. They may or may not, by and large. An additional month of infertility beyond the average reduces the chance of pregnancy by 2% or about 25% per year. So every time we are waiting for one year beyond 2 years, it is reducing their chances further by about 25%. For each year of female partner's age, which is more than 30, the pregnancy rate is reduced by 9%. Every year after 30, it is, but this one is young. In unexplained infertility, the average cycle fecundity in the untreated group is around 3.8. So see, unexplained infertility, when you diagnose, their fecundity is supposed to be very low, ranging from 1.8 to 3.8. and prognostic factors, like when you want to wait or do a expectant management, what are the best prognostic factors, which is the duration of infertility, less than 2 years, a previous pregnancy in the same relationship, and a female age less than 30 years. So I think in our patient here, she only conforms to this, which is the female age less than 30. She is married for 2 years already, and she's not had any previous pregnancy. So I think majority of us, at least my situation would be such that I would definitely want to do something after 2 years that she is married. And expectant management also, I think you said, Rima and others, you all said about expectant management. And you all maximum, I think, will wait for 1 month, 2 months by giving her some kind of advice, not more than that. Now, I think, Anupama, you should answer this. I'll ask these again very specific so that, we can get some kind of a answer. Who of you would want to do a diagnostic hysterolaparoscopy in this patient?
I would not go for diagnostic hysterolapro in this patient as a first instance.
Okay,
Somehow,
others, let me take the opinion of others. Anybody in the panel who want to do a diagnostic laparoscopy?
I'm in for diagnostic hysterolaparoscopy.
So, Dr.
I'm
Ritu
in.
would like to go for diagnostic hysterolaparoscopy. Anybody
Even
else?
Dr. Sujata, even for me, I think if I have to further evaluate her, I'll go for diagnostic hysterolaparoscopy, because in history, she's giving history of mild dysmenorrhea. She could be sitting on mild endometriosis.
Mild dysmenorrhea is
and
there.
be picked up by doing a laparoscopy.
Mild endometriosis.
Because you have already said that everything else is normal. Her tubal function is normal. Her ultrasound is normal. Her edges, semen analysis is normal. Hormones are all normal. The only significant
So I think I should now ask Anupama as to why she would not want to go for diagnostic hysterolaparoscopy.
yes, specifically, I wanted to answer this.
Yes.
Because the first investigation.
I'll come back to you, Dr. Rima. I'll come back to you.
Because the first
I think majority of our panelists will not go for a hysterolab. We'll come to each of the tests that I have mentioned here, but we should quickly say hysterolab, because most of the gynecologists will think in terms of hysterolab. So
Yes.
I want to get your opinion as to why you will not.
Yes. See, in this patient, I am actually suspecting that she might be having mild endometriosis just because of her history.
Okay.
But I would rely more on my scanning rather than going for an invasive investigation, which is hysterolapro.
I really love you. I really love you, Anupama.
Because, I should not flaunt this, but this is a very, very easy diagnosis on ultrasound. And nothing much is gained by, if you are not finding anything on ultrasound, the chances of that mild endometriosis, you can still miss on diagnostic, and you are not going to gain anything by doing a diagnostic hysterolapro. You just treat her on line of mild endometriosis. As it is, I'm going to think this patient is having mild endometriosis straight away, and I would go ahead thinking of that.
Yes, so that
Even if I'm
definitely
not-
is the point. Have a look at this scan. My own scan I had done myself. Absolutely normal uterus. Look at the mobility. Look at the cavity. The ovaries are correctly placed in their normal position. Normal, good antral follicle count. You can see the mobility of the ovaries. There's a nice corpus luteum out there. The other ovary is in the right place. That's also looking good. That also has a mobility. It's correctly placed in the pelvis. What more will I find in an ultrasound? In a diagnostic laparoscopy. So, but then I am not saying that diagnostic laparoscopy is not the answer.
Tubal function can be evaluated.
Yes, Dr. Rima.
Excuse me, madam. This scan is also saying it's a micropolyps.
No, there is no micropolyp. Micropolyp by scan?
Yeah, they are very small micropolyps. There is irregularity in the endometrial lining.
No, I don't think so. But let's not go there. Right. So tell me, Dr. Ritu, Rima.
Ma'am, why I would not want to go is, first, it is an invasive test, and even if
you also would not like to go for diagnostic lab.
No, ma'am.
No, but let's okay. You tell me, then we'll hear somebody who would want to go for scan
So I was the one, Dr. Sujata, who said that I want to go for a laparoscopy, because one, you've already said that the ultrasound is normal, everything else is normal. So now we are looking at what next. The test which you have enumerated. Among those, if you want to build upon what is her tubal function, or, if we are missing upon something in her unexplained infertility.
You have a point. Majority of people would like to go for a diagnostic histo lab, but the gynecologist who's doing their own scan, if they're satisfied, usually 99% of the chances you'll not find much. The endometrial cavity also sometimes, if in this case, if you can see some micropolyp which you cannot by ultrasound, but even if you feel there are something in the which you will find in hysteroscopy which you'll not find by scan, you can do it immediate post menses, so that you will have a very thin cavity line. But whatever, there is a point to both the tests. That's why I wanted to say. Right, Rima, we interrupted you. Tell me, Rima.
Yes, I have a point to make here, ma'am, because even if I do a histo lab and if I do find mild endometriosis, my treatment would still stay the same. I would still pick up this patient for ovarian stimulation and IUI, and this adding another invasive procedure, which is also taking money away from the patient.
Right. So we will come back. So your points are absolutely right. Now I have a very interesting, very short video, very, very rare, of course. But Anupama, this is for you. Now there are some subtle things.
There are possibility of tuberculosis also.
Tuberculosis also.
I'll come to that.
Hidden tuberculosis is also become much common in India.
Yeah,
in which
there is
the
another test.
ultrasound
We'll
seems
come
normal.
to that. We'll come to that. We'll come to that. So okay,
we can
now
find the
this is a
tubercles over the tubes.
दिखाने दो सुजाता को.
Mild adhesions could be there on laparoscopy.
Right.
Because
Usually
we can't
even
label
in mild
laparoscopy as
endometriosis,
an invasive test. We can't label laparoscopy, hysteroscopy as an invasive test, because it's for the benefit of that patient only. And many times we see
but it is
subtle
an invasive
lesions also.
test.
We can diagnose COX on this laparoscopy, which could have been missed on TVS ultrasound. Many a times seen, and many a times the follicles which we see on ultrasound are small pockets of endometriotic cysts. Many a times when we puncture, the chocolate fluid comes out, which seems follicles on this. So not ground glass appearance is not very much common in endometriosis. In severe grade endometriosis, obviously we'll find a chocolate cyst, but in mild grade endometriosis, many times
there is no correct answer.
Chocolate cyst.
Diagnostic histolaparoscopy is a very standard test, very, very commonly done. And of course, we each has to take their choice based on the patient who is sitting in front of them, and whether you would want to do, whether you'll gain anything or not. So there's no doubt that there's no right answer. Both are right. But then there is one thing
we see the
which we cannot judge by anything.
Actual reserve of ovary is seen on laparoscopy. Many times the thick cortex is there, white ovary is there.
No.
Many
Let's
times
not
the
go there,
follicles
doctor. I think ovarian reserve we
many
cannot
times
see on
we see the actual
laparoscopy. There are many
reserve
other ways of seeing ovarian reserve.
Laparoscopy.
So the point
So
that I
it
was
could be
trying to
for the
make,
benefit of the patient only.
Yeah.
I think the biggest advantage is those, mild flimsy adhesions. The tube is slightly kinked, and we have seen so many times that you do mild adhesiolysis, and you do mild, cauterization of the lesion. And there are a lot of patients who conceive after histolaparoscopy. So in a country like India, in unexplained infertility, histolaparoscopy not only as diagnosis but also as a treatment modality has a very big role, I feel.
I would like to add something.
Dr. Sumita.
I'd like to add something. Since we have found out everything is normal in this particular patient, for first 3 months we can go for ovulation induction only and mild ovulation induction. If she is not able to conceive for first 3 cycles, then we should go for laparoscopy, because there might be peritubal adhesions, as Sumita is speaking about. It can cause infertility in such cases.
So that's what I said. Any of the third 3 choices you could have taken. So you would like to go for treatment for 3 months and then go to the next step. That's also fine. Certainly you can do any one of the 3 options. That is why I gave. But let's say you want to investigate. Now see, this is one this thing that I wanted to show you, a short clip of very old clip of a patient. So there is one thing which we cannot judge by ultrasound or by HSG or any other test, which is the tubo-ovarian relationship. That is the most important thing which we cannot see. Yeah. Now see, this is a absolutely normal scan, absolutely normal by laparoscopy. There is no endometriosis, nothing, clean pelvis. But see how It is such a long, the ovary is placed right at the pelvic brim and the tubes are facing the liver. It's facing the upper abdomen. And there is no pathology, but some kind of maybe a congenital or some kind of a congenital strand, the peritoneal strand or something like that, which is keeping the tubes fixed at this position on both the sides. Now, this patient can no way get pregnant because see here, to both the sides, it's like that. Both the sides, the tubes are facing
short and long tubes, both are cause of
and
infertility.
there's a very long ovarian ligament and a very short IP ligament, and the tubes are kind of very, again, as I said, there was no pathology, so it was looking like. So TO relationship is one thing which you will only know by. So today's discussion is like, see, unexplained infertility. In any case, in our field, as in medicine, we can never be dogmatic about anything. And so everything is right. And we have to see what suits the patient sitting right in front of us. Okay. So now the second test, so diagnostic histolaparoscopy, we vary. Some people would do.
One thing I want to add, sometimes a pad of fat is there at the fimbrial end. Also, pad of fat is there in cases of unexplained infertility, or a range of small parafimbrial cysts are there that makes the fimbria heavy, and that's why this ovum is not picked up. So that may be also seen on this laparoscopy. Heavy fimbrial end because of the pad of fat or a bunch of small
I am not aware. If you have read about that being a etiology, must be I am not yet aware of that. I'll check it.
I've seen, ma'am, and I've dealt with that patient on the.
I'll read. Okay. Now the second thing is, any one of you would want to do ovarian reserve tests in this patient? Let's go talk only about this patient, because I have not done any ovarian reserve test as a first line investigation.
She's 26 and her scans look fine. The antral follicle count on the scans look fine. So AMH, as of right now, we do know that the AMH and the AFCs correlate very well. So if she was beyond, that would not be my first line test. I do believe on my scans. I do believe on the antral follicle test that I see. But yes, sometimes AMH could be a more kind of a, thing that for writing or for documentation. But if you're very confident about your scans, then AMH and the antral follicle counts, and all her routine hormonal tests are fine. So AMH may not be mandatory in her because she's
anybody
young.
In the panel? Yeah.
LH has got a role. LH has also got a role.
Is there anybody else in the panel who would like to do further ovarian reserve tests?
I would want to go for.
I would also like to
even
go
though
for
I can see
I think if one person would speak, it would be nice.
I would go for a AMH, even though I see a good antral follicular count, but still for quantification in a patient which is 2 years plus, maybe later on it would be required. So I would go for an AMH, ma'am.
Is that Akriti? I can't see you.
That's Anupama.
Everybody.
That's Dr. Anupama.
Anupama.
Okay. Even I would like to go for AMH test. It will give us the baseline, and also many patients AMH comes high sometimes. So she may be she may have like PCOD type of a thing. So like.
No, PCOS is a clinical diagnosis. We have to have at least oligomenorrhea.
No, that's what I'm saying. Clinically, she might
so
not.
Let's not go towards PCO.
I would go
so you
for
would like
FSH
to do...
and LH also. FSH and LH also. FSH and LH also.
Okay. So some of us would like to do
FSH and LH if the FSH is on the higher side. FSH is on the higher side, towards 10. It depicts the oocyte quality. FSH has also got a role in ovarian reserve testing. If it is on the higher side, that is towards the 9 or 10, it explains a kind of sub-infertility.
Right.
So that we may want the patient
in the panel,
FSH is on the higher side.
Everybody is speaking,
So
I am not understanding.
treatment.
Is there anybody in the panel who would not like to do ovarian reserve test?
AMH
Anupama?
is very important, madam.
I said that I would want to go for one test only, and that would be AMH. I would not do a full battery of investigation. One investigation, antral follicular count, I've already done, and one AMH is another investigation that is my baseline investigation on which I built on my patient.
Perfect.
So I want to.
Dr. Rima, you were saying something?
Ma'am, from various studies, it has been proven beyond doubt that AMH and AFC correlate very well nowadays. So although we do have AFC, but I agree with Dr. Anupama that I would want for documentation purposes and completion purposes.
Okay. So I think that is fine. I just wanted to put across one point when I said this. Of course, the patient is young. And it depends on, based on the situation, you'll decide whether you'll do a ovarian reserve test or not. But there's one point which is, sometimes there is something called a biological age and chronological age, and unexpectedly you will find a very low or an unexpectedly low AMH for that particular patient and that particular age. Maybe that is one of the reasons why you may consider doing an AMH. But as I would also agree that I would only want to do AMH and correlate it with AFC. I would at this time not want to do any other test like FSH-LH. But that, of course, is you have to take your call. Now, what about tests for genital cocks? Would you want to do this? Let's start with Josna. Dr. Josna?
Ma'am, in Indian scenario, yes, we should do.
So that means you will go for a hysteroscopy or you'll go for a diagnostic hysteroscopy and do the test? And what test will you do?
Ma'am, nowadays interferon, TB interferon is what is.
So you'll do a blood test for cocks?
Blood
How
test
will that be genital cocks?
TB PCR with endometrial blood. First day we call the patient, first day of menses period.
Yeah, so you'll have to take some genital fluid, no?
Yeah. TB PCR for the endometrial tissue.
Okay, so you would always want to test for genital cocks in this patient since she is unexplained? No, we are only talking about this patient, no? Only then we can, discuss about.
Ma'am, we should test for this patient. I would like to do this test. Yes.
Everybody in the panel would want to do a test for tuberculosis, or is there anybody who would not test?
I think
now, this scenario somehow these days are changing, and we are seeing low people coming out with a positive COX reports in spite of doing
low or high. I couldn't hear you.
Our belt we are seeing, ma'am. Dr. Shiva, like in Uttarakhand, many people come with the positive TB PCR test. That's what.
My experience has been that TB, if you have genital COX, it would really do damage to your lining of the uterus and the tubes. Now, most probably 90% of the people with tuberculosis would have their tubes or the uterus affected, and you would see something or the other, either the lining, which is very poor, the basal endometrium is gone, or so
what test will you do? My question is, what will you test?
Ma'am, it has to be an endometrial curettage. You take, just an aspirate.
What will you test it for? TB PCR, DNA PCR, RNA PCR,
even if I have
histopathology, culture, AFB, what?
No, I was just answering that. If I have to do, it will be an endometrial aspirate for culture, which is the gold standard.
Okay.
And because we now know that the PCR is not a test which is valid for treatment. You cannot start patient on an ATT on that because the dead bacteria can still be picked up.
Absolutely.
Anytime. So definitely not the PCR, because even if the PCR has to be done, it has to be an RNA PCR, which is very unstable. Most labs will not be doing the RNA PCR. So I would definitely go for a culture. If I need to get the reports early, I would request a backtack so that I get an early report, and not maybe the culture which takes 6 weeks to come. And if my suspicions are very high for tuberculosis, maybe after the first week, second week report, if they're still negative, if my suspicion is too high, I just might start an ATT, which is, I don't know then why I'm doing the test also, if my suspicions are too high. So as I said,
of course,
I
if
am
there
not
are suspicions of clinical, signaling of COX, you will go for that.
That's the only thing. So, but the point is that these days I have seen that the number of the tests that we were sending for tuberculosis and the number of the reports that we got for positive, they were mainly for the PCR would come positive, but the cultures would definitely come negative. And because we were trained at centers and we were taught by people who were more based on cultures, we have slowly shifted from a time when we were doing EA as a routine for all patients to EA which may be a suspected patients, because yes, where we were finding that the reports were coming positive, we did had an associated either a uterine factor or a tubal factors. Purely patients where ultrasounds were completely normal, we would not find a test which were positive, and hence we have shifted away, or me gradually over time have shifted away from a practice of doing EA as a routine for TB.
Right. So I think you've covered almost all of genital, what is the important points, and really thank you for that. But certainly I think about genital COX, the most important point should be that there's a lot of geographical, socio-economical variation in its prevalence. And the gold standard is to see the sequelae of tuberculosis. And in test, it should be culture at least, or at least a AFB staining. And so as a clinician, we have to take a call as to whether we would want to do a test for genital COX for this patient. Okay, and then what about DNA fragmentation? Is there anybody in this, for this patient, let's only consider this patient. Anybody would want to do a genital, do a DNA fragmentation for this patient? I saw this paper, that's why I put up this question. This paper which said that somebody has said, some professor, around 80% of couples who are diagnosed with unexplained or idiopathic infertility have a known cause called high sperm DNA damage.
Actually,
so, what about DNA fragmentation? Are you people clinically doing that or no? Or would you believe in doing this?
We have to weigh the cost benefit.
Put them on an antioxidant.
No, we're talking about the test. Is there anybody, do you believe in this test? Would you want to do it? No. Okay, so let's move ahead. Let's move ahead. I do a lot not because of anything, only for research. And we do it more for recurrent pregnancy loss, less for unexplained infertility. So let's not go there. But
so let us hear from you, Sujata, since you do a lot of DNA fragmentation. What's
your... as I said, my people, they do a lot of research on recurrent pregnancy loss and male factor. That is why we do a lot of our patients, even with two abortions or unexplained infertility, we do a lot of sperm DNA fragmentation tests in a research setting.
Okay, that's fine. But what is your interpretation? Do you think that it was helpful?
It was extremely helpful and correlating very much in recurrent pregnancy loss, but not so much in unexplained infertility.
Okay. Thank you.
Okay. So now for this patient, let's see that she is 2 years, blah, blah. She's not married. She's busy. She wants to get pregnant. You're not finding any cause. Out of the various options that you have, you've decided to do some tests, decided not to do some more tests, but then you have to do something for her. So what would be your choice? Other than the people who would like to do expectant management for maybe a couple of more months, what would be your choice? Would you go in for a timed intercourse, just ovarian stimulation, ovulation induction, or ovarian mild stimulation, or would you want to go in for IUI? Each one of you can just give your choices.
Letos with timed intercourse, we can tell them that is a good alternative. And usually the conception rate is also seen. Like,
yes, but would you do a follicular monitoring or no?
Yes, with follicular monitoring. If OI is given, then follicular monitoring has to be done.
Anybody in the panel would want to start off with IUI in this patient?
Me, ma'am. I think for a young patient, 26-year-old, all investigation normal, we have to go in a stepwise manner. And I think, obviously, we all know gonadotropin stimulation plus IUI would give the best results. But I think giving a step-by-step chance, there are so many patients who conceive only on ovulation induction. We know that even with clomiphene and letrozole and timed intercourse, around about 8 to 10% patients conceive. So yes. I think for me, my first line would be, yes, giving her ovulation induction with simple ovulation-inducing agents and timed intercourse. And of course, with a time-bound fashion, if in 3 months they don't conceive in timed intercourse and they're anxious to get pregnant, then probably I will shift to IUI. Definitely IUI will be with ovulation induction because that would be giving them the best results.
Excellent. Dr. Rima, you wanted to put a point?
I differ here, ma'am. if I do ovarian stimulation for unexplained infertility, I would always combine it with IUI because we don't know what is at fault in this patient. So the idea here is that we are trying to correct, like ma'am said, molecular levels here. Probably we are trying to increase the gamete densities and, take care of not so obvious things which are not being picked up. So for just working upon one partner and, we don't know where the cause was. So if I'm doing something, this is not an anovulatory one, I would always want to combine both.
To IUI and see if you can overcome some other factors which IUI overcomes.
Yeah, but definitely.
Excellent. I'm so happy the panelists are so varied in their opinion, and that is the best part of this panel,
Yeah.
I think.
But then,
That's
Dr. Sujata, what I feel that we can't actually say that ovulation induction alone has no role. We have to see everyone is based in a setup. Every patient who's coming is not coming prepared that, okay, now I'm in, unexplained infertility. If I'm going for, ovulation induction, it must be combined with IUI, because over the years, we have seen that so many patients superovulate with the letrozole and with the clomiphene, and they have conception with timed intercourse. So we can't actually say that 8% and 18% difference is zero. Cost also matters, and then IUI is also invasive. It has its own issues.
And you also have to see, like I keep saying, you have to see.
So I don't agree to that in a 26-year-old just married for 2 years, maybe for 6 months, they were just not even trying for pregnancy, that she comes for a treatment and then we straight away jump upon IUI. I think we should give them a chance of superovulation with timed intercourse. If that fails, then we switch to IUI.
So when you say superovulation, would you use a clomiphene citrate, which has a more chances of multiple ovulation than a letrozole?
We'll see. Definitely now we have shifted almost 90% of our patients to letrozole.
Letrozole will be mostly mono-ovulatory, because one of the aims of overcoming unexplained infertility is to increase the gamete number. Right?
But CC has its own.
Does anybody agree
on
with
endometrium?
Me? That we should maybe go for CC or letrozole? Do you have a choice? I think we'll have to finish. It's 6:30 already.
I would go for letrozole and rather than CC. If I would have to add something
else. For letrozole?
Yes, definitely letrozole. And if required, I'll add gonadotrophins. And not CC.
One for CC. Okay. So so let me just sum this up, and then if we have time, if you tell us, otherwise we can wrap it up here. I had another case. So the treatment, of course, in case of unexplained infertility aims to increase the chances of pregnancy every month and shorten the time to pregnancy. That is our aim. So improve gamete quality, gamete number, and facilitate gamete interaction. So these are some causes. I don't have to read. We are already running short of time. We've had such animated discussions. So there are so many causes. The most important thing that we can have, absolute causes are very less, those who are directly connected to pregnancy. There's so many causes that we can have for which there can be infertility or subfertility. And there are so many putative and so many unlikely causes also. For example, there are so many causes, mild and, let's say the best example is mild and minimal endometriosis. We know that even fertile people have that much prevalence of. The best paper that I read was that in a cohort of patients that was undergoing tubectomy, if you see what is the number of women with mild and minimal endometriosis, it will probably be the same as when you're doing a diagnostic hysterolaparoscopy for infertility. Yeah. So anyway, expectant management is the best choice, less than 2 years. We've discussed that, so let's not go there. So Aarti, do you think we can discuss or we should stop because it's already 6:30?
We can move ahead.
Yeah, maybe second case we can quickly discuss because your cases are so interesting and we have a lot of audience logged in.
The audience is fantastic, Aarti. We have such small points also. We are discussing so much. It's fabulous. And everybody has such strong opinions, and that is the best you can hope for in a panel, in your panelists. So quickly, we'll not discuss too much. So now this is a woman who's 33. She's married for 5 years.
They all are 5-star rated topmost gynecs who are sharing their magic
I know.
points here. So a lot of people want to hear them. I think we'll quickly take the second case also.
ठीक है, maybe maximum 10 minutes.
Yeah.
Because even I need to go. So this one is 33 years old. She's married for 5 years. Her pelvic scan, her diagnostic laparoscopy, and her tubal patency, which was done 3 years back. And her seminal fluid analysis is normal. Her routine blood tests, pelvic scan on day 2, antral follicle count is 4 plus 5. Day 2, her hormones are normal. Her AMH is 2.81. She has had multiple cycles of ovulation induction and 4 or 5 cycles of IUI, which has been done elsewhere, and she's never been pregnant. And now she's coming to you because she's considering ART. Now, before planning IVF fixie, now we have to do this quickly. Will you do a diagnostic hysteroscope?
Yeah.
No,
Who's
ma'am.
answering? Anyone can take this? Or maybe Kriti, Dr.
Ma'am, the guidelines clearly state that
Anupama.
Well, I would not go for diagnostic hysteroscopy.
अरे बाबा ये तो बिल्कुल लैप्रोस्कोपी हिस्ट्रोस्कोपी करना ही नहीं मांगती है रे.
No, ma'am, the guidelines clearly state that even if we have not done an IVF and we don't find anything, the scans are normal, the hysteroscopy is not recommended. It's
only after a failure that I would go for.
We are not discussing guidelines, right? At this time, we are not discussing guidelines. We are, of course, the guidelines tell in a cohort of IVF, pre-IVF, you are not expected to do a diagnostic hysteroscopy if your scan is normal. Only in cases of recurrent
implantation failure,
you might consider a hysteroscopy. So anybody who will do a diagnostic hysteroscopy or nobody will do?
See, Dr. Sujata, I do a lot of office hysteroscopies, and I feel that office hysteroscopy has become such a wonderful tool. It has given eyes to our, as good as like the way ultrasound.
I can't see people who are speaking here.
Sumita.
Have you put off your cameras? I mean, your videos.
No, it's on, ma'am.
Everyone's video is on, yeah.
Why I can't see? Acha bolo. Then?
Yeah. So I do a lot of office hysteroscopies. And then believe me that every month, I would say that we pick up 4 or 5 patients who had like unexplained infertility with polyps, with synechia, and then quite a few of them, do conceive after a simple office hysteroscopy, giving us the clues of unexplained infertility, like,
no, but we are talking for this patient.
Yeah. I'm also talking about this particular.
She is for IVF.
Yeah.
You're going to take her up for IVF in the next cycle.
Yeah. So I am one person who likes to do office hysteroscopies for my IVF.
You might find subtle causes like a certain adhesion band in the fundus or something like that. You'd like to do, create a nice cavity or whatever.
Yes,
Small
and
polyps we like to remove.
Office hysteroscopy does not require anesthesia. It does not require hospitalization. It is a 15 minutes procedure. It makes my ET so much more easier. I'm not stuck with a difficult ET.
Okay, so are you a believer of endometrial scratch to improve your chances of pregnancy?
No, not in every patient. Only in failures, or if I'm looking at the small cavity.
Like you said, now that might act as a
scratch.
Yeah. If I'm looking at a poor endometrium on my ultrasound or something, but I'm not somebody who's routinely doing endometrial scratching because there's not enough evidence for that. But yes, I do a lot of office hysteroscopies.
Okay. And will you also take a endometrial fluid at that time for genital cocks?
Yes, I test all my patients for genital cocks before IVF because there's a lot of litigation involved. If a patient with IVF fails and later on she goes to another center and she's picked up with genital cocks, then you have a lot of problems.
They might just pick up one DNA also and then you might be in trouble.
Yes. Yeah. So it is important now to be very, very comprehensive with your investigations. And if you have done an office hysteroscopy and documented at least that you have not seen any evidence of cocks, later on, even if this patient is picked up, you have something to fall back and say that, yes, I had made an effort to look for cocks, even if not in blood.
So that would be your standard test pre-IVF. Now, what about a scan, a 3D scan? This question should go to Anupama, I think. 3D scan,
yes, definitely.
Endometrial and artery blood flow studies.
100% I'll go for a 3D scan for this patient.
What
has to be done.
Look at that 3D scan. Are you a believer in dysmorphic uterus and their reduced chances of pregnancy?
Yes. And it is so very common here in our part of the world.
Dysmorphic uterus is common?
No, the small Mullerian abnormalities, small septums, subseptate uterus. That is really very common here.
Okay, so if you find
but
something, then only you'll take them up for hysteroscopy.
Yes.
What
No, but
about
I
blood
think, Dr.
flow?
Sujata, we are looking at two different things. Both of them are complementary. When you do a 3D ultrasound, you're looking at vascularity, you're looking at congenital abnormalities, you are looking at small polyps and everything. But on 3D, it is difficult to pick up synechia. It is difficult to get a guidance about how you're going to do your embryo transfer. So
Sure.
I think both of them are complementary towards each other.
When you
Offices
say
for
both,
Turkey,
you mean hysteroscopy and 3D? No,
I think I do 3D ultrasound. We do ultrasounds for all our IVF patients. And when we are doing the evaluation of cavity, it is so easy to just put them on a 3D evaluation and watch the cavity. So I think there's nothing, doing a Doppler and doing a 3D scan for an IVF patient should be a standard thing, I think now. So both of them are complementary to each other.
And endometrial blood flow studies. What about genetic studies?
No.
Because she's a case of unexplained, that's why I'm asking all this.
No, not so.
If she would be a tubal factor and you're taking her up for IVF, I wouldn't ask this. Anybody who
don't
believes
do this.
No?
No, ma'am, we're not doing this. Until unless we don't have failures, we are not doing
with unexplained
MTHFR gene
infertility.
studies. We are doing MTHFR gene studies only when we do find recurrent implantation failures. That is when we start doing those APLA and look for antiphospholipid antibodies.
So not
we're
as
doing
a
this-
routine in cases of
No, ma'am,
unexplained.
we're not doing as a routine in unexplained infertility. Ma'am, if you look at the number of the tests, it will keep on increasing and we won't even find the C where to, where we would
No,
stop
but I'm
screening.
asking this question from the point of view of this patient being unexplained infertility.
Ma'am, if we
Our
go back to the
chairperson said we should find some cause of infertility. We should.
Ma'am, I do
right.
agree to ma'am that she said, but if we go back to the question, we could find the cause there that her antral follicle counts are low. So she would have a poor ovarian reserve. She has a reserve of 4 and 5, which is something which is very uncommon at the age of 33, which you gave us. So I think if we look at the question the answer starts there. That is the antral follicle count, which is low for her age, which would define what could have been the reason why she's not conceiving, though we know that the egg factor or basically the egg count
No,
do
but
not
there are
fall
so
into
many
the
subtle
criteria of
factors also, no? There are so many factors which we don't know.
Ma'am, I do
can
agree
lead
to
to-
that, but as we say that, ma'am, if we look at there, I think that would be at the end of the day, that may be the determinant of why things may not have been working, rather than maybe some other question, other things that we're looking at.
Right. So
what
what about DNA fragmentation? Rima, you wanted to make a
I just want to say a point, since you said which all tests would you do? So, ma'am, in unexplained infertility, there would be no end to testing. So, genomics, proteomics, metabolomics, everything is coming up in such a big way. What all are you going to test? And so
I'm just asking you about those tests.
we won't do all this because doing an IVF itself is correcting so many disorders in the first go. So these tests may not end up giving, increasing their all we are trying to do is increasing their chance to get pregnant in the shortest possible way.
Like many in many Western countries, probably they'll go in for all these tests even before a patient plans a pregnancy.
Ma'am, but most of the cycles, most of the treatment
I am not supporting any of these. I am just putting a point. What about DNA fragmentation?
Sponsored by the government if you're less than
No, and we are not contesting that. We are not contesting that. I just made a point.
That is what I'm saying. Here the patient has to pay it from the pocket, and sometimes we have to rationalize whether we want to save the money for the testing or save the money for a treatment where they would get a higher success rate. So we need to balance that out, because sometimes, as ma'am said, that these all tests, if we combine them together, they would cost a few thousands to their pocket. And maybe I would like to save that money for a good IVF treatment cycle.
Well, now this is $1 million question. I wanted to hear everybody's opinion about this IVF or ICSI.
Yes. Now this particular
patient. I'm a tenant of IVF. I'm sorry.
1 minute. Let me put the question first. Give me a chance. So this patient, I took her up for for ART cycle, and with 150, 300 IU for about 11 days, we got about A2 sites, 7 M2. Post-wash, 28 million, 90% mortality. Okay? Now, IVF or ICSI? Just one word. IVF or ICSI?
ICSI. ICSI.
ICSI.
ICSI.
Anybody ICSI?
No, ma'am.
My take would be half IVF, half ICSI.
No, ma'am. I would.
कोई बात नहीं, 3 पर IVF, 4 पर ICSI.
Because there
so
are
many
so
times I've
many
seen that
fertilization questions in. So many times I've seen,
Sujata,
already
that
saying 7M2,
ICSI
so
would
that
not
means-
give us result, but IVF would give us results. And sometimes it is the vice versa.
But you are always scared of IVF in an unexplained infertility.
Yes.
And she's
Yes.
a patient who has had 6 cycles of IUI failed. Her antral follicle count, her AMH is 2.8, not too bad. You know, she's one of those patients who's got not too bad in ovarian reserve. 33 years with 2.8 AMH, you should expect good quality oocytes. So I think I would be thinking more towards, fertilization failure, and I probably would be much more comfortable going for ICSI for this
So I
kind of
think
a
most are
patient.
happy with ICSI. Only Anupama is wanting to do IVF half and half ICSI. Right?
Yes.
Okay.
7M2, I think all ICSI would be safest.
Yeah, for me also, I would feel that. But then you have a point, I agree. Now the final question. What about fresh embryo transfer or a mandatory frozen embryo? Unexplained infertility.
Mandatory FET.
Who said that?
Anupama.
Fabulous. What about the others?
I will see how many.
I would go for an FET cycle.
Ma'am, we would like to, mandatory FET will be better because we'd like to prepare her uterine endometrium, and of course, FET has shown to increase the implantation rate. So I'll go with
FET has not been shown to increase implantation and live birth rate in a normoresponder.
But
only in hyper responder, it may.
Oh. For this
that is the evidence-based study. Come on, listen. The evidence-based based in practice and practical management of the patient are two different things.
Ma'am, what we are seeing is these days we have had higher success rates with the frozen embryo transfers, even though the literature and the evidence says that it would fare the same, but we have started seeing that the frozen embryo transfers have been found to be much more giving us higher success rates, but maybe because we're combining all sorts of patients from poor ovarian reserve to PCO patients, but it's more of like the endometrial preparations is better. Patients are less anxious post pickup. You are able to, ma'am, it gives us a lot of time for us to plan a cycle, not just plan a cycle, because we're able to do a mock transfer. If we are believant of empirical therapy, we have time to start that, do that. So I think that is the advantage of doing a frozen embryo transfer as compared to a fresh embryo transfer.
So like I said from the beginning, there are no right answers. There are only opinions, and there is evidence to support either this or support either that. And patients are very, very variable. And so generally we have to take a call. So I think I'll just finish now with a short takeaway, which is expectant management has a role in correctly selected couples. Clomiphene citrate is more effective than letrozole for superovulation, timed intercourse, or IUI. Gonadotrophins are even more effective. We know all that, but then multiple pregnancy and OHSs will rise. In fact, sometimes gonadotrophin IUI OHSs can be, equally as bad as when you're doing IVF. Despite cost and invasiveness and widespread use, IVF was not very much superior to gonadotrophin IUI, but time to pregnancy is certainly shorter. So there was a very nice set of, this thing I had kept. This evidence, but we don't have the time to go through that. It was a very recent meta-analysis, 2019. We'll discuss that another time. That showed that whatever we discuss today, ultimately the evidence is not there to support any one of them for unexplained infertility. Whether you should take IVF or you should do IUI, whether you should do just ovarian stimulation or you should do expectant management. There's so many choices, and we just do not have enough evidence to support one over the other. The only point that we can say is that OHSs and multiple pregnancies are more with IVF and gonadotrophin IUI, And the only other thing that we can tell with certainty is that IVF will reduce time to pregnancy. I think that should be the guiding factor when we are talking to our patients. Thank you very much.
Thank you, ma'am.
Thank you for the very crisp take-home messages, Dr. Sujata. Amazing. Very nice messages.
Wonderful presentation, wonderful panel discussion, Dr. Sujata. It was a very interactive and our panelists were very knowledgeable. And
But it is interactive because of the panelists. They are so strong, and they have their opinion and they stick to it. And that is what I love about it.
Yeah. That was really
That is how
good.
it should be.
Yeah. Many points, every points have been discussed, and it was a very interactive and very informative panel discussion. Thank you, Dr. Sujata, and thank you all the panelists. Thank you, Aarti and Akriti, for giving me the opportunity to chair this session. And everything has been talked about. Thank you very much.
Thank you. Thank
Anybody
you.
has the
Bye-bye.
answer to the
Dr.
question
Sujata,
that
excellent
what is the
panel
treatment
discussion.
of long tubes?
There was one question.
Pardon me?
I don't know. What is the treatment of long tubes? There is any method to reduce or reposit it? Nothing?
I am not aware. It can cause maybe
Yeah,
increased
I am
chances
not
of
aware.
ectopic pregnancy. Other than that, I don't know.
Yeah, really.
I think it is just congenital. We just have to accept it that you have long tubes, be it. If you get pregnant with it, good. If you don't get
Lucky,
pregnant, it's for IVF. Yeah, you
Most
can't
of
do
the
nothing
time they
about it.
can have tubal pregnancy, as Dr. Sujata is telling. I have found that one of 2-3 of my patients in this career, they conceived by IUI, not naturally. I have seen. I don't know what is the reason behind it. Everything is normal. They have unexplained infertility, and most of the time, the 2 of my patients, they conceived by IUI, not by mild stimulation. So what is the reason behind it? And Dr. Sujata will tell, can we do anything to reduce the length of the tube?
Nothing.
No studies yet. Huh? Thank you so much, Sujata. It was wonderful session.
Sujata
Wonderful
has some work. Akriti, you can
Enjoyed
quickly
it. Thank you. We
note
could
of
have
place.
gone on for a long time, but we have to stop.
Yes.
Lovely.
Thank you.
I hope we'll meet each other in person soon. Aarti.
Definitely. Yes, Dr.
Yeah.
Sujata, let me know the month. We'll organize a nice physical CME here.
You all plan.
Maybe
Chalo.
July, August. Yeah. Thank you.
Thank you. Bye.
It was nice interacting with everyone. Thank you so much.
Thank you.
Thank you, ma'am. Thank you,
Dr.
ma'am. This is
Akriti.
Ranjit, ma'am.
Thank you, everyone.
Thank you, ma'am, for giving us an opportunity to being associated with such a wonderful webinar.
Big thanks to all the chairpersons, learned panelists. Walter Bushnell is always with us. And thanks, Dr. Sujata, for a great start. And I think you should quickly tell everyone about the ISAR Gurukul. That program is also doing very well. I was seeing the topics are very good.
Thank you, Dr. Aarti. Thank you, Dr. Akriti, for organizing such a nice webinar and very interactive session. And I think everybody has enjoyed this academic feast. Thank you all.
Thank you.
Thank you, everyone. Thank you, Sujata ma'am. The case scenarios were so amazing. We learned very practical points, not just theory, as you said. No, I don't know about the recommendations, but yes, the practical points. And Nanita ma'am's talk was to the point, crisp, and perfect. I would take time to thank our chairpersons, Dr. Vinita ma'am, Ruchira ma'am, Binu Vesh ma'am, and Upendra Uli sir, who have taken out their valuable time and given out their opinion towards this wonderful topic. And lastly, I would like to thank our panelists who were so enthusiastic in the panel discussion, and our organizers, Dr. Aarti Luthra ma'am and the Walter Bushnell Ranjit ji, who have been coordinating very well. Last but not the least, all the delegates, all the clinicians who had joined into this webinar and made it into a huge success. We got a good attendance and it was such an interactive session. I would thank everyone, each one of you. Thank you so much.
Thank you.
Thank you, Dr. Akriti.
Have a wonderful evening.
Thank you.
Thank you. Good evening.
Have a wonderful evening ahead to all of you. Thank you, ma'am. Thank you, Akriti, ma'am.
Thank you, Rachit ji.